The broadcast is now starting. All attendees are in listen-only mode.
Welcome everybody. My name is Olgica Laban-Grant. I'm one of the epileptologists in the Northeast Regional Epilepsy Group. And today I will present you the topic about the epilepsy and women issues. I will give you a brief overview of complex interactions that are necessary to regulate women's hormones. And then we will review the interactions between hormones, seizures, and epilepsy, and anti-seizure medications. We will also discuss the effects that this may have on different reproductive stages in women's life. At the end of this review, I'm hoping that you will be able to identify issues that are pertinent to you and be able to discuss them in more detail with your physician. Epilepsy affects approximately 1% of the population. It is very common neurological disorders. That means that about 50 million people worldwide have epilepsy. In the United States, that's about 3 million people, and approximately 1/2 are women. We estimate that about 500,000 are women of childbearing age. Incidence, which is frequency of the disease, is slightly higher in men. In men, there is about 49 cases of epilepsy per 100,000 people, while in women it's about 41 cases per 100,000. We believe that this is because some of the risk factors for epilepsy, such as strokes and head trauma, are more common in men. However, if you look in specific types of epilepsy, and if you listen to the previous webinars, you remember that there is a generalized epilepsy and partial epilepsy. Generalized epilepsy is more common in women, about 58% compared to 42%, mostly because of the slightly higher frequency of juvenile absence epilepsy and juvenile myoclonic epilepsy syndromes in women. When we look at partial epilepsy or localization-related epilepsy, it can be divided into partial epilepsy of uncertain origin, also known as cryptogenic partial epilepsy, and symptomatic partial epilepsy, which is partial epilepsy of known origin. Cryptogenic partial epilepsy is more common in women, while symptomatic partial epilepsy is more common in men. Again, we believe that this is because some of the risk factors that are more common in men. Also, the characteristics of the seizures within certain epilepsy syndrome may differ between men and women. When they looked at the temporal lobe epilepsy, they found out that women are more likely to have isolated auras without progression into generalized tonic-clonic seizures, while men have more frequently secondary generalized seizures. We are not sure why this is happening, but the studies, anatomic studies, not in people with epilepsy, but in general population, have showed that the wiring of the brain is different in men and women between the temporal lobe and frontal lobe, and that maybe because of that, the seizures in men are more likely to spread than seizures in temporal lobe epilepsy in women. However, men and women have similar risk for recurrent seizures and similar likelihood of ultimate remission of epilepsy. Now we will switch to our next topic. Interactions between hormones and anti-seizure medications in seizures and epilepsy are complex. During this talk, I will try to address each part of this interaction separately. However, you will see that that may be very difficult because there is a lot of overlap in these mutual interactions. I will start first with a brief overview of the complex interactions which are necessary to regulate women's hormones throughout the different reproductive stages in women's life. This overview should just show you how many levels are influenced by the brain, glands, and hormones, and therefore may affect the regulation of the menstrual cycles, the onset of the menopause, or onset of the first menstrual cycle. Major sex steroid hormones in women are, as you know, estrogen and progesterone. They're both released by ovaries. However, ovaries are under control of the brain, part of the brain which is called hypothalamus, and gland that is called the pituitary gland. This axis or these interactions form the system which is called hypothalamic pituitary gonadal axis, or HPG axis. And I will just briefly explain some of the interactions just to present to you the complexity of the control. So this is HPG axis, so the major components are the hypothalamus in the brain, pituitary gland, and ovaries. The neurons, the brain cells in the hypothalamus, produce this substance which is called GnRH, gonadotropin releasing hormone, which then is released in pituitary gland. Pituitary gland then produces different hormones. One of them is called FSH, which is follicular stimulating hormone. What this hormone does is stimulates the production of the follicles in the ovaries, which then produce the estrogen. Now, estrogen is released in the bloodstream, and estrogen can affect brain. It can affect the hypothalamus and pituitary gland. And by this effect, it triggers these structures in the brain to produce this new hormone, which is called LH, luteinizing hormone. And as a result of that, there is a sudden surge of this hormone somewhere in the middle of the menstrual cycle. So around the 14th day of the menstrual cycles, or at the end of the so-called follicular phase. Follicular phase is called that because there is a follicle that is producing the estrogen. And as a result of this production of this new hormone, LH, ovulation occurs. So the egg is released approximately in the middle of the menstrual cycle. What happens next is that this new hormone, LH, stimulates this follicle to produce progesterone. And the second phase is called luteal phase of the menstrual cycle. And during that second phase, or second half of the menstrual cycle, we have both production of estrogen and progesterone by ovaries. And both estrogen and progesterone can affect the brain and the glands in the brain, and therefore may affect the further production of these hormones in the ovaries. What happens at the end is that if there is no conception, no pregnancy, the levels of the progesterone and estrogen drop, and at that time this lining in the uterus starts to shed, and that is actually the onset of the menstrual period. And after the onset of the menstrual period is over, the whole cycle starts all over again. However, some of the cycles are called anovulatory cycles. These are the cycles in which there is no release of the egg. And we will see that these cycles are more frequent in women with epilepsy. These menstrual cycles look the same, and the woman who's having an ovulatory cycle cannot differentiate from ovulatory cycles from anovulatory cycles, because they last approximately the same, and there is the menstrual period at the end. However, as you can imagine, this can affect the fertility rate in women who have frequent cycles in which the egg is not released. We will now focus on the interactions between seizures and hormones, and influence that seizures may have on hormones. The studies have shown that seizures may affect this HPG axis by direct effect on the brain and production of the hormones released from the brain, such as this gonadotropin releasing hormone, which is produced by hypothalamic neurons, and indirectly then can affect the production of the other hormones and the regulation of the menstrual cycles. However, interestingly, some of the studies have shown that not only seizures, but also those interictal discharges that Dr. Laban-Grant showed you in his first webinar can also affect the function of the brain. So it's not necessary to have seizures to have the influence of the epilepsy on the HPG axis. As a result, women with epilepsy have more frequent menstrual cycle irregularities. So the duration of the menstrual cycle is different, and in most extreme cases there is absence of the menstrual cycle. Also, the rate of fertility is slightly lower, sexual desire may be decreased, and women with epilepsy have early menopause. Menstrual disorders are estimated to occur in 1 out of 3 women with epilepsy compared to 1 in 7 in the general population. So they're more than double or more than twice of the frequency in general population. And also, 1/3 of menstrual cycles in women with generalized seizures are anovulatory, so there is no production of the egg. One specific syndrome that I wanted to mention is polycystic ovary syndrome. That is the syndrome which is defined by the presence of 2 out of 3 of following: multiple cysts in the ovaries and high male hormone levels, which can cause the excessive facial hair and acne. Other associated features are obesity, irregular menstrual periods, and again more frequent anovulatory cycles. This syndrome is twice as common in women with epilepsy. It occurs in 10 to 25% of women with epilepsy compared to about 7% in general population. Possible explanations for this association is 1, that seizure activity in brain alters the production of the hormones, as we discussed just minutes ago. However, valproic acid or Depakote also causes features similar to polycystic ovary syndrome. We don't know whether this medication actually causes polycystic ovary syndrome, but it causes some of the features that are similar to this syndrome. And it has been shown that when women who have these symptoms were switched from Depakote to Lamictal, that some of the characteristics disappeared. We believe that these menstrual disorders are related to the effect of the seizures on the brain, because it has been shown that the seizure characteristics may lead to different abnormalities in the menstrual cycle. Hypogonadotropic hypogonadism is the big word for actually lower production of that hormone, gonadotropin releasing hormone, which then can have effect on the production of the other hormones by ovaries. This is more common in women with the right temporal lobe epilepsy and right-sided discharges on the EEG, while the polycystic ovary syndromes were more common in women with the left temporal lobe epilepsy and left-sided EEG discharges. Again, we do not have the explanation why this would be the case. Epilepsy can affect sexual desire. The reason for that may be dysfunction of the brain, dysfunction of the frontal and temporal lobes due to seizures. So if you have seizures that are arising from either frontal or temporal lobe, these parts of the brain are very important for the sexual desire, and because of this dysfunction, sexual desire may be decreased. Anti-seizure medications may have an effect on the hormones and therefore decrease the sexual desire. They also may be sedating and cause sleepiness and tiredness, which obviously will cause decrease in sexual desire. And finally, psychological or social factors may be responsible because many men and women with epilepsy are sometimes nervous about possibility of having a seizure during the sexual intercourse. Women with epilepsy have lower rate of fertility. Contributing factors is early age at the onset of the epilepsy, and also it's more common in women who have partial epilepsy or localization-related epilepsy. This is slightly different. Women with epilepsy have fewer children. That is not only because of lower fertility rate, but because of the other factors also. One of them is choice, and some of the studies have shown that women with epilepsy express fear of having a child with birth defects because of the sexual dysfunction, as we previously discussed, because of the more frequent menstrual disorders, and maybe a higher frequency of polycystic ovary syndrome. Next, we will discuss the effect of hormones on seizures. Hormones, female hormones, may change the excitability of the brain and alter the threshold for seizures. In general, and very simplified, estrogen decreases seizure threshold, while progesterone increases seizure threshold. What that results in is the estrogen theoretically increases frequency of seizures, while progesterone will decrease the frequency of seizures. This brings us to the topic of catamenial epilepsy. This is epilepsy in which there is the association of the frequency of seizures with certain times in the menstrual cycle. These are also called hormone-sensitive seizures. And this can be any type of seizures, generalized or partial seizures. Estimate is that approximately 1/3 of women with epilepsy has substantial relationship between seizures and menstrual cycle. And it was also found that this is more common in women who have left temporal lobe epilepsy. So in catamenial epilepsy, seizures tend to cluster in relationship to menstrual periods. Possible explanation is that this correlates with the time during the menstrual cycle when there are high levels of the estrogen, low levels of progesterone. This may also be related to the fluid and electrolyte imbalance that may change the excitability of the brain and seizure threshold. Also due to the fluctuations in the levels of the hormones, the levels of anti-seizure medications may change. And finally, due to the psychological stress. I will just briefly remind you of the levels of the estrogen and progesterone during the menstrual cycle. So this is the typical 28-day menstrual cycles. For approximately the day 14 is the day of the ovulation. So this is called follicular phase, and in this phase the estrogen is produced and rises. And then after the ovulation, progesterone starts to be produced by the ovaries and increases. If there is no pregnancy, both hormones decrease and new cycle starts. It was shown that some of the women have clustering of the seizures just before the ovulation. And the reason for that, we believe, is because there is this steep rise in levels of estrogen. And as we previously mentioned, estrogen decreases seizure threshold and makes seizures more likely. This is called catamenial pattern 2. So just before the ovulation, day 14, due to steep elevation in estrogen. The second pattern is just before the menstrual period. And the reason for that is believed to be this steep decline in levels of progesterone. So, as I mentioned before, progesterone increases seizure threshold and makes seizures less likely. So at this time when there is a decline in the levels of progesterone, seizures may be more likely in some women, and this is called pattern 1 of catamenial epilepsy, just before menstruation due to steep decline in progesterone. So it seems simple. You will keep your diary and you will see where your seizures cluster. Is it in the middle of the cycle or towards the end? And we can diagnose it with catamenial epilepsy. The problem that arises is these anovulatory cycles, which, as I mentioned before, are more frequent than in women with epilepsy than in general population. What happens during these anovulatory cycles? Egg is not released. So there is no increase in production of progesterone. Progesterone stays low, while the estrogen continues to be produced. So the estrogen continues to decrease the seizure threshold, and these women during these anovulatory cycles will have increased seizure frequency throughout the second half of the menstrual period. So this is pattern 3 of catamenial epilepsy in second half of menstrual cycles, and sometimes starts even in this, before the day 14th because of the rise in the estrogen. This is because there is no elevation of progesterone to oppose the high levels of estrogen. So what should you do to determine whether you have catamenial epilepsy? You should keep diary of your seizures and menstrual periods for at least 3 months and discuss this possibility with your neurologist. What your neurologist may do is may increase doses of anti-seizure medications during particular type of the menstrual cycle, or possibly add another medication during these days to control seizures better. The other option is supplementation with reproductive hormones, usually natural progesterone. And this supplementation may be cyclic, so just during the certain period of the menstrual cycle, or suppressive. And this is, for example, Depo-Provera, which are injections which are given every 10 to 12 weeks and suppress menstrual cycles, and therefore decrease these fluctuations in the hormones and decrease the effect that hormones may have on the seizure clustering. We will now switch to the effect that anti-seizure medications may have on hormones. We'll talk mostly about the exogenous hormones. So these are hormones in the birth control pills and hormone replacement therapy during menopause, because most of the data that we have about hormones comes from this type of studies. Some of the anti-seizure medications decrease efficacy of birth control pills and other hormonal birth control. This may result in birth control failure and unplanned pregnancy. And some of the studies have shown that over 50% of women with epilepsy reported having unplanned pregnancy. Anti-seizure medications that interfere with birth control are hormonal birth control are carbamazepine or Tegretol, phenobarbital, Delantin or phenytoin, primidone or Mycilin, Benzel or Phenamide, and at higher doses Topomax or topiramate and Trileptal or oxcarbazepine. Anti-seizure medications that have no influence on levels of steroids are gabapentin or Neurontin, Lamotrigine, Lamictal, levetiracetam or Keppra, Tigabin, Gabatril, Zonisamide or Zonegran, pregabalin, Lyrica, and lacosamide or Vimpat. What are the possible solutions? One, and most obvious, is using anti-seizure medications that do not interact with birth control pills. Luckily, these are some of the newer medications that also usually have better side effect profile. Two, using alternative birth control methods, such as IUDs and barrier methods. And third, which is least popular, is using birth control pills with higher dose of estrogen. So the birth control with higher doses of estrogen also means that, for example, Depo-Provera has to be given more frequently. If there is a breakthrough bleeding in the menstrual cycle, that usually suggests that the birth control is not effective. And then the dose of estrogen has to be increased again, or women should use another method of, in addition to birth control pills, another barrier method. Pitfalls of this approach is that there is no proof that the higher dose of estrogen is sufficient, and absence of breakthrough bleeding is not proof of efficacy of birth control, so it's really not a good measure whether the birth controls are good or not. And finally, as we know, estrogen may increase frequency of seizures, and therefore the seizure control may become worse with increasing the dose of the hormones in the birth control. As for IUDs, there are two types that are available. Copper IUDs and hormone releasing, or Mirena, which has progesterone. Since the effect is based on local influence of hormone on the uterus lining, it is unlikely to be affected by anti-seizure medications. However, we do not know that as a fact. Epilepsy and hormonal replacement therapy. So the hormone replacement therapy that is used in menopause to alleviate some of the symptoms of menopause increases estrogen levels and may increase seizure frequency. And sometimes use of natural progesterone with estrogen may help. And also the anti-seizure medications that are used may have an effect and make the hormone replacement therapy less effective. So that also should be taken into account when this hormone replacement therapy is started in menopause. As for the hormones that are produced by the body, there's some indirect data that anti-seizure medications may affect them also. Because after the withdrawal of the anti-seizure medications and carbamazepine or Tegretol was the most commonly used, there was significant increase in the serum testosterone in both men and women. Also, we discussed earlier that there is a possible association of valproic acid and polycystic ovary syndrome, or the features similar to the polycystic ovary syndrome. We will now talk about the hormones and anti-seizure medications. We have the most information about Lamictal or Lamotrigine. Estrogen component of the birth control pill and hormone replacement therapy is decreasing levels of Lamictal. And there is very pronounced effect in pregnancy on the levels of Lamictal, with a steep decline of Lamictal levels during the second and third trimester. As for the other anti-seizure medications, we know about the effect of hormonal shifts on certain type of the drug metabolism, glucuronidation, which may affect other anti-seizure medications. Two medications that are metabolized by this process are valproic acid or Depakote and Trileptal oxcarbazepine. So they may be affected by hormones. However, we do not have direct evidence that this is true or that this has any clinical significance. That means that it has any real effect on the seizure frequency. We will now switch on discussing the different stages in the women's reproductive life. We'll start first with pregnancy, which is very important part of the women's life, and this is one area of concern for many women with epilepsy. It is important to know that over 90% of babies, and probably over 95% of babies born to women with epilepsy, will be healthy. And we believe that this number may be higher if pregnancies are planned. However, although low, birth defect rate is still about twice of rate in general population. So about 4 to 7% compared to 1.6 to 3.2%. Most common major birth defects are neural tube defects. Those are defects in which there is a defect at the different level of closing of this lining around the spinal cord, heart abnormalities, and orofacial clefts. Some of the health problems that are more frequent in babies of women with epilepsy is low birth weight and reduced growth potential, learning disability, and somewhat high risk of epilepsy at about 3%. What causes high risk for birth defects during pregnancy? Seizures during pregnancy, some anti-seizure medications, and also there is some genetic predisposition for the birth defects. What can you do about seizures? We learned that women who have better control of seizures prior to pregnancy usually have fewer seizures during pregnancy. So it's worth trying to get good control of seizures before you even try to conceive. Sometimes there are seizures during pregnancy, or there is increase in seizures of pregnancy in about 1/3 of women with epilepsy. That may be due to non-compliance. And usually that is because some women, when they find out that they are pregnant, they decide to stop their medications, which may be very, very dangerous, because of inability to take medications because of the nausea and vomiting, because of the changes in the metabolism of the anti-seizure medications, and because of sleep deprivation. As for anti-seizure medications in pregnancy, more birth defects are found with polypharmacy, so in the women who are on 2 or more anti-seizure medications, and also women who have higher levels of medications throughout the pregnancy. So what we are trying to do before pregnancy is to try to simplify the anti-seizure medication regimen and decrease the amount of medications while maintaining the seizure control, and also to try to decrease the dose of medications if it's necessary to continue medications throughout the pregnancy. It is important to know that not all anti-seizure medications are the same. And one that stands out is Depakote or valproic acid, which is associated with the higher rates of the birth defects and also some learning disabilities in kids who were exposed to Depakote throughout the pregnancy. This is the information that was published by the North American Pregnancy Registry in spring of 2012. Some of the numbers are not the final numbers. That means that there's not enough women in the registry to come to the final conclusion. So for example, if you look at the Exogenous, it says that there is a birth defects are 0%, so we should really switch everybody to Exogenous. But there are not that many women who were on Exogenous during the pregnancy, and therefore this result is not as accurate as for some other anti-seizure medications. The North American Pregnancy Registry tracks use of anti-seizure medications and pregnancy outcomes. All information is confidential, and it's very important for women with epilepsy who are pregnant to contact them and participate in their study, because that greatly improves our knowledge about the anti-seizure medications during pregnancy. So what can you do about anti-seizure medications? Your neurologist or epileptologist will consider reducing medications to single medications, or switching you to monotherapy, changing you to the medication that has better profile during pregnancy. They will try to decrease dose of the medication, or in some cases even stop medication. This, however, has to be carefully balanced with the seizure frequency. So the seizure control needs to be maintained because seizures also increase the risk during pregnancy, and should always be done only under close supervision of a neurologist. Folic deficiency is associated with increased risk of neural tube defects. Anti-seizure medications that are linked to folic acid malabsorption are phenytoin or Dilantin, carbamazepine, Tegretol, barbiturates, and Depakote, valproic acid. So what we try to do is to start all women of childbearing age on folic acid, and especially if you're trying to conceive, you should start taking folic acid in months prior to trying to conceive. So these are the important points. It's very important to plan pregnancy because first you need to achieve good seizure control. You may need to change anti-seizure medications and give it enough time to make sure that the changes in doses of medication are still maintaining good seizure control. You need to start folic acid in months before pregnancy. Also, start prenatal vitamins before you're trying to conceive. You need to develop good relationship with your neurologist or epileptologist, and also with your OBGYN, and high-risk pregnancy OB is preferred because you will need to be under their close supervision throughout the pregnancy. Also, you should discuss possibility of genetic counseling with your obstetrician, especially if there is a history of birth defects in family. Once you're pregnant, you need to continue taking medications. Do not stop or decrease taking medications without discussing with your physician. You should consider prenatal testing, should continue taking folic acid and prenatal vitamins, and you need to continue close follow-up with your physicians. What is prenatal testing? This is testing that may be done during pregnancy to detect some of the birth defects. These are the three major types of prenatal testing. At the weeks 15 to 22, maternal serum alpha-fetoprotein is measured in the woman's blood. In the weeks 16 to 20, you may undergo level 2 or structural ultrasound, which can detect some of the birth defects. And finally, between the weeks 50 and 20 of pregnancy, you may undergo procedure which is called amniocentesis, which in which the small amount of the fluid around the fetus is taken and analyzed for different disorders. Many women ask, why do prenatal testing? Well, some birth defects require special attention during pregnancy or during delivery. Some birth defects may require surgery immediately after delivery or even before delivery. For example, some studies have shown that in the babies who have spina bifida, so they have the problems with the neural tube, sometimes surgery may be done even before delivery, and that may improve the outcome. And finally, sometimes it may be helpful to have enough time to prepare for a baby with special needs. The next important thing is to measure the levels of the anti-seizure medications during a pregnancy, because in the second and third trimester, the levels of the medications may drop significantly despite continuing to take the same dose of medication. Levels drop in the second and third trimester because the changes in the metabolism, because of the changes in maternal plasma volume, because of the changes in the binding to the proteins of the medication. So the frequent testing and adjustment in dose of medication may be necessary. And pregnant women may require much higher doses to maintain the same levels to prevent breakthrough seizures. I just wanted briefly to mention hemorrhagic disorder of the neonate because there are some anti-seizure medications such as Tegretol, phenobarbital, and Dilantin which can compete with vitamin K across the placenta. And because of that, the newborn may be more likely to have a bleeding disorder, and what we are mostly concerned about is bleeding into the brain. Luckily, all newborns get a shot of vitamin K to prevent this disorder. However, some obstetricians prefer to place pregnant women on vitamin K in the last month of pregnancy. Recommendations or guidelines regarding this practice are not clear, but it's something that you may want to discuss with your obstetrician if you're on one of these medications. After the delivery, anti-seizure medication levels may increase again, so the close monitoring and decreasing of dose of medication is necessary. Sleep deprivation and stress may increase frequency of seizures, so decreasing dose of medications has to be carefully balanced with this. And finally, you may have to prepare your house for some special child safety and lifestyle adaptation. As for breastfeeding, all anti-seizure medications are released into the breast milk. The medications that bind to protein have lower concentrations than those medications that do not bind to protein. However, this is the same medication that the baby was exposed during the whole pregnancy to. And it is believed that the small amount of the anti-seizure medications and potential risks are overweighted by the overwhelming benefits of the breastfeeding. So general recommendation is to breastfeed babies, but to observe them for irritability, poor sleep patterns, or inadequate weight gain, which may be some of the possible side effects of the medications that is released in the breast milk. We will now talk about puberty and adolescence. Most seizure disorders are not altered by onset of puberty. However, some of the seizure disorders, such as juvenile myoclonic epilepsy, may start at the approximate age of the first menstrual period, or some of them may improve at this age, like benign Orlandic epilepsy or absence epilepsy. Also, rapid growth may account for the poor seizure control. When the woman has the first menstrual period, we usually discuss catamenial epilepsy and make the girls aware that they may need to follow up their menstrual cycles and the frequency of the seizures to determine whether they may have this type of epilepsy. We also discussed very early interactions of anti-seizure medications with birth control pills and make them aware that some of the anti-seizure medications may make hormonal birth control less effective and may result in unplanned pregnancy. We start folic acid supplementation, and we also discuss pregnancy and make them aware that they need to let their physician years in advance about planning pregnancy so their medications can be adjusted timely. We also discuss choice of medications and side effects of medications, because some of the medications may affect appearance and therefore may not be very popular at this age. We discussed the effect of substance abuse on the frequency of seizures, the effect of sleep deprivation, which is very common in this age, on the increase in frequency of seizures. We discussed compliance to medications, which is frequently a big issue at this age, driving and state laws regarding driving, sport safety, and choice of profession, because some of the professions may not be as adequate for the women who are expected to have epilepsy through their lifetime. Next, we're going to discuss menopause and perimenopause. So this chart on the right shows the hormone levels during the premenopause. So these are the menstrual cycles. The hormones go up and down in the regular intervals. And then perimenopause is the period in which the menstrual cycle becomes irregular. It's the transition to the menopause when the menstrual cycle ceases. And this chart shows how chaotic hormonal levels are during this period. So the effect on the seizures is impossible to predict. And then in postmenopause, the levels of the estrogen and progesterone are low. Premature menopause is more common in women with epilepsy. It occurs in 14% of women with epilepsy compared to 3.7% in general population. And it occurs on average 3 years earlier than in general population. It is correlating with estimated lifetime number of seizures. So the less seizures, less likely to occur early. And so far, we didn't find any correlation with the anti-seizure medications. Effect on seizure frequency is unclear, as both estrogen and progesterone levels will drop. However, it seems that catamenial epilepsy improves during the menopause because these fluctuations in the levels of the hormones are also not present. During menopause, the doses of anti-seizure medications may have to be changed due to changes in the metabolism. Usually they have to be decreased. Usually there are other medications that woman has to take, so the interactions with these other medications have to be taken into account. We will briefly discuss bone health, and we already discussed hormonal replacement therapy and the effect that the anti-seizure medications may have on its efficacy and the effect that the hormonal replacement therapy may have on the frequency of seizures. Fractures are more likely in people with epilepsy due to falls, which may be the result of seizures or may be the result of side effects of anti-seizure medications, but also because the bone density due to certain anti-seizure medications may be decreased in men and women with epilepsy. Altered bone density due to the anti-seizure medication is associated with phenytoin, dilantin, carbamazepine, tegretol, barbiturates, and valproate or Depakote. In women or men who are on these anti-seizure medications for more than 6 months, we usually recommend usual healthy, balanced diet, exercise, stop smoking, moderate alcohol, moderate caffeine, so the general measures to decrease the decrease in bone density. Also, calcium and vitamin D supplements are usually recommended. We measure calcium, alkaline phosphatase, and vitamin D yearly, and also we obtain baseline bone density scan. We refer these women to endocrinologists for possible treatment if bone density scan shows osteopenia or osteoporosis, if we see abnormal blood levels, or if the women have fractures and that may not be caused by the sufficient trauma, so-called stress fractures, so-called pathological fractures. We can help us to learn more about these issues, and at the end of this talk I would like to invite you to help us gather more information and clarify some of the issues that we discussed earlier in this talk. Northeast Regional Epilepsy Study is currently conducting a research study on epilepsy and women's health issues. The objective of this study is to collect information on the seizure patterns in women with epilepsy and to examine how it affects women's health. Inclusion criteria are women aged 12 to 70 after first menstrual period. The study consists of the questionnaire completion, which usually takes about 20 to 30 minutes, and then women who are still having menstrual periods will fill this 3-month calendar of menstrual period and seizures. I would also encourage all women who are pregnant to register with North American Pregnancy Registry to help us gather more information about the effect of anti-seizure medications on pregnancy. Thank you very much for listening to this webinar, and if you have any questions, please email them to email this that is provided in the invitation to this webinar.